would like to invite Dr. Muhammad Hashim to talk to us about abnormal gaits in 10 years old.
Good afternoon, everyone. Thanks, Mr. Chairman. So it's a few minutes to go through the gait, which is not an easy job. So it's a 10 years old child present to your elective pediatric clinic with this gait. So we'll go through the next few minutes how to approach this patient. So speaking about abnormal gait, we need firstly to know, I have nothing to disclose firstly, so we have to understand what's normal gait and what's abnormal and how to deal with that. So we'll go through the gait definitions, prerequisites, biomechanical principles, and the traditional kinematics, kinetics, and assessment. Then we'll go to the main part of the lecture about the common differential diagnosis of abnormal gait in children. So to define a gait, it's an energy-efficient translatory progression of the body as a whole due to coordinated smooth movement of the body segment. So with any abnormality of this definition, we'll go to the abnormal gait. So to say an abnormal gait, it may be energy inefficient, unsmooth, uncoordinated, or poor body progression. So what is normal gait? So you need to understand the definition of the normal gait. So stance face, which means your foot is on the ground. Swing face when your foot is off the ground. Step when it's between the one foot, the initial contact of one foot and the other initial contact, and the stride, which is the whole gait cycle, which is an initial contact between one foot and the same foot again. You need to understand the foot progression angle, which is angle between the foot and the line of progression. So some prerequisites for a normal gait. So to have a normal gait, you have to have a balanced foot when you're standing on it. You have to easily clear your foot while you're doing a swing face. You need to reposition your foot before you go for the next initial contact. You need to have an adequate step length, and this gait needs to be energy efficient. So there is few principles. If you can go through them, you will understand the gait. So you always have one complete foot on the ground at a time. So when one foot is striking by one heel, the other foot is toeing off. So you have only one complete foot at a time on the ground. To get the gait to be energy efficient or preserving gait, you need to use the power of the ground reaction force to move your joints in a passive mood without using any energy. And if you need to use the muscles either to control this gait or to do an action, you need to use them in eccentric position. So eccentric contraction is the most preserving energy mode. You need to understand that your foot have three rockers. So the heel strike, which is the heel rocker, then the flat foot, which is the ankle rocker, and then before the toe off, which is the forefoot rocker. Foot moves as a unit. So when you're putting your foot on the ground, so once you do a heel strike, your foot starts to pronate, extend, and rotate. So the mid-foot joints are suppled because the plane of movement of the talonavicular and calcaneocuboid joints are in the same plane. So your foot is supple and easily accommodating the ground. And other way around when you do a toe-off. So when you do a toe-off, your foot supinates, so the line of action between the talonavicular and calcaneocuboid is in a different planes. So your foot is rigid, so act as a lever to push you forward. And as you see on the right hand side, so the weight goes through the foot from the heel going to the lateral side, then to the toe. You need to understand tibia rotation. So when you're putting your foot on the ground, pronating, extending, rotating, at the same time your tibia is internally rotate. While you're loading, your tibia is shifting forwardly, and this controlled by your soleus. And then when you're toeing off, your tibia is moving externally. There is a good understanding about the knee flexion extension coupling. So your knee is moving from extended position when you're doing a heel strike to move forward. And this movement is controlled by the soleus. Till the moment that your knee is extended, then your knee again is flexed during the swing phase just to get the foot clear from the ground. Your pelvis moves in an 8-shaped direction. So externally rotate on the stance side, tilting up and down more on the stance side. and then moving front and back. So ending by this 8 movement, which is reducing the movement of your center of gravity. Kinematics of gait, so stance, which is 60%, and swing, which is 40%, going through different phases. And this is a kinetic, what each muscle is working. And as we agreed, if the muscle is working in an eccentric contraction, so it's more energy efficient. How to assess a gait? So you must go through the history, very detailed history, physical examination, and on the right side you can see a chart for physical examination from older high Liverpool, which is very fantastic. You can go through every bit of the examination. You need to do functional scoring, and then you go for gait analysis, which starts with some video from the front, from the back, from the side, sensors over the muscles and the joints, which is giving you an idea about the kinematics and the kinetics of the movement, EMG to give you an idea about the muscle action, and ending by testing the pressure of the foot over a foot plate, which we call pedobarography. So this is the gait analysis lab in Older Hay, Liverpool. So foot plate, sensors over the muscles and the joints, and cameras from everywhere videoing the movement. So what's the common differential diagnosis of an abnormal gait in children? It could be habitual, like a two-walking gait. It could be due to pain or trauma, at the commonest antalgic gait. It could be because of rotational profile abnormalities like the in-toeing gait. And it could be due to joint pathology like the stiff gait. And it could be due to neuromuscular problem like the CB, which give us the characteristic crouch gait, stiff knee gait, and the spastic diplegic gait. Could be due to cerebellar injury like the ataxic gait, and it could be due to neuropathy, giving you the high steppage gait, and lastly, myopathic gait, which is a wide-based paddling gait.
And
so we have a look at this.
gait refers to a painful
It's very characteristic
The
antalgic
patient's
gait,
stance
which we
phase
cannot
will be
miss.
shortened on the affected side.
So two-walker, which is sometimes is habitual and sometimes become pathological and problematic, especially if in elder age. So on the right side, you can see just the habitual in-toeing, which is very simple rotational profile problem. And on the left side, you can see the malignant one, which has a miserable malalignment with both patella looking forward, not looking forward, looking internally, and both feet are looking internally. If you see this child who is barely moving the joints, so he's walking with very stiff gait over all the joints. So this is a characteristic stiff gait in a CB joint, a CB child. Then when you see this position of gait, which is really characteristic, so patient, as you see, moving with flexed hip, flexed knee, barely do any heel strike, which is characteristic crouch gait. If you have a look here, so this patient is walking while the rectus femoris is firing, so he has no knee flexion, which is the stiff knee gait. Back to our friend, so he's, as you see, walking with internal rotation, with just circumduction both limbs in a very characteristic spastic diplegic gait in a CB child. So this kid is walking, if you have a look on her right leg, so barely move this leg, she's just circumducting the pelvis just to clear the foot from the ground, which is very characteristic of a hemiplegic gait on the right side. And the characteristic like drunk movement, so he's walking like a drunk because he has an ataxic gait from a cerebellar injury. This child, if you see, he clears her foot by flexing the hip and knee, because unfortunately his step anterior is not working for some neuropathy or an injury, which is giving the characteristic high steppage gait. And lastly, this young child is walking with characteristic waddling gait, so wide base, moving both sides because of weak abductors, which give us a picture of myopathic waddling gait. So take home message, you need to understand the normal firstly, you need to assess properly history examination and gait analysis, you need to identify the pathology, and then accordingly you have to treat the patient. Thank you so much.